So again, I just have to, by the way, acknowledge the fellows at our hospital who really were excited to help put together cases. So if the slides look beautiful, I did do a little editing, but they really put in the legwork here. So first of all, I have to almost end the session with my cute puppy slide. Sorry, just to get you guys all revved up, and we are pediatricians. Yes, this is Lexi. She's a mini golden doodle, F1B. She's almost a year old, and she runs my household.
What does F1C look like?
F1B. So yes, it's mostly poodle. So, and she's got the attitude. So that having been said, so now you've learned about my golden doodle. So we have a young woman who is now almost 17, but at 8 years of age presented to one of my colleagues with multiple issues: diarrhea, mouth ulcers, hair loss, malnutrition. So clearly Crohn's disease was top of her differential. She was born in India, but had moved to the United States in infancy and had no recent travel or ill contacts, and really had no significant past history of any gastrointestinal diseases or autoimmunity in the family. So when she came to the hospital, my colleagues noted that she was cachected, had angular cheilitis. You can see that she was profoundly hypoalbuminemic, anemic, elevated platelets, negative infectious stool studies, and I'm going to show you colonoscopy pictures. There was actually the EGD pictures I didn't have, but I tried to hunt them down, but I was told it was one very isolated aphthous ulcer, so it wasn't really clear in the second portion of the duodenum whether this was truly because of Crohn's or just an isolated small aphthous ulcer. The colonoscopy was noted to be fairly impressive, but no stricturing disease and no TI involvement that I'm going to bring up. So you can just take a look. Again, had just deep ulceration throughout, predominantly in the right side of the colon, and then more scattered aphthous ulcers on the left side of the colon, but again, no TI involvement and no stricturing. So initial therapies, got enteral therapy for 8 weeks, was placed on methotrexate, gained weight and grew for a little bit. So then in 2009, had recurrence of weight loss, recurrence of anemia, so they added Pentasa, but the anemia persisted. So then had a repeat scope in the spring of 2010. So the bottom line, I'll be asking questions soon, y'all.
I can't hold back.
I know, but don't worry, I knew you couldn't, so that's why we've got a question slide really soon. So endoscopically, had mild colitis, cecum ascending rectosigmoid, severe colitis, transverse descending, scattered apathy in the rectum, and now in the TI as well. And the histopath basically supported this. So I knew you guys were going to be chomping at the bit, so I'm going to ask. So what changes in therapy would you make? And actually, I'm going to do a retrograde question and say what therapies might you have started. And again, we're not here to indict what folks have done, but just trying to figure out how we would sort of approach this. And is there any additional testing that would need to be done? All right, so Dr. Dubinsky.
No. Okay, so I think one of the themes that I've seen at the meeting is this idea that 2 points. One, we need to risk stratify a patient and decide in our own practice what we use as tools to say this is a high risk of complication patient versus mild. The moderate is difficult and in between, but at least the identification, is this a patient that I need early effective intervention? And early effective intervention could be enteral nutrition. That's not an issue, but it's the maintenance strategy. Right. If you want to sort of talk about it in this case, is that right colon is basically asking to come out in the absence of some mucosal, very active, assertive, biologic type of treatment. You got to go after the biology in a patient like this. The minute you go below the mucosa and you start having these bear clawed type ulcerations, that patient, unless you hit it hard up front, you're really going to run into trouble. And although God bless methotrexate, but it does not have the power, in my opinion, for someone who her albumin was 2, she was anemic, she hadn't grown. Which part of ever data, I'm sorry, there are no pediatric data in a randomized fashion with metho, that's 1. 2, where is the data to say that methotrexate has that systemic biologic capability with a lot of growth failure. There is none, as far as I know. But there's a lot of data on the role of pentasa. No, I'm kidding. In very deep ulceration. So, I mean, I think those are the kind of main things before I tear my hair out and ask you who can do that.
Well, and I'm going to add, since I again, this is way before my time. I've only been there for 11 months. It wasn't the fellows. They weren't even born when this patient came to Children's. And I will say that I did a little chart searching. I do think this was a family that was resistant to any therapies at all, or wanted to go more the natural route, sort of in defense. And so I think to possibly, and again, I'm probably reading into it because I didn't actually talk to the original attending, but just reading phone messages, I think there may have been some hesitation with anti-TNFs. I will say, so this is where discussion is important.
What you just said is not possible.
Yeah.
Because you're telling me that methotrexate was discussed with this family as a safer alternative to anti-TNF.
But I think, and this is one of the things as physicians, I think our thoughts have changed, but there are still some folks out there, not necessarily all of you in this room, but there are people out there that have this message that the anti-TNF is, quote, the last resort. And I still see this with family discussions, and if you guys read patient blogs, so I'm just bringing this up. Yeah, but no, I'm not disagreeing. Yeah. Dr. Griffiths and Dr. Suskind. No, I see both of you.
Well, just the other thing that's really important, and I think often very helpful when it is a family that is pushing back, I think most of those families, they truly believe that what they are going to do, whether it's changing diet or whatever, is going to reverse the Crohn's. They really do believe it's going to heal the bowel. So what we can do is we can take a look again and assess the bowel. And I think that's been the other big take-home message at this meeting in the adult talks, especially when they're debating one class of biologics against another. They're certainly saying whatever you do, look and see what it's achieving. And so often families that might be pushing back, when they see that their hope hasn't materialized, they're often more willing to move on.
Yeah, I would agree wholeheartedly. I think the key is making sure that we have really close follow-up with these families and patients. The dilemma is that if they're feeling better, which we know a lot of our therapies will do, but we're not getting that mucosal healing, then oftentimes you're not able to intervene until it's much more significant and we have to send it over to you. We do have a protocol where we actually initiate EEN and then begin actually dual therapy for individuals who are extremely sick, like this child presented with.
Well, so it's going to get better, but so they went on steroids and 6-mercaptopurine was started. Again, still the discussions, but as we've heard, we're not going to Monday morning quarterback. So anyways, April through December continued to do poorly. Ongoing inflammation. One could argue that it's not completely surprising. But the CTE in December of 2010 showed that there was a colonic stricture. So remember, I've said there was inflammation. We now have a stricture. Lialda was added. So we have this MR. Dan, you can go through and tell us what your thoughts are, or anybody else. But bottom line, marked wall thickening. And I always say that if I can see something that looks abnormal, then it must be, because I'm not a radiologist. Hyperemia, dilation of the transverse colon with active inflammation. It's not so clear here, but also had what looked like the beginnings of a stricture. The question is it fixed or more inflammatory at this point? And one could argue most likely it's still inflammatory. And then wall thickening of the distal ascending colon. So it looks pretty significant. Any thoughts initially? Anyone? Dan?
Well, so from a surgical standpoint, I think the child needs an operation. What you do in the operating room to some degree depends on what the distal bowel looks like, but in a sick child like this, I think you would probably lean toward resecting the stricture, resecting the bad part of the colon, and doing a diverting ostomy. see if you can heal the bowel and then put it back together later.
Has she grown at all?
No, and I'm going to be showing some pictures soon. So the colonoscopy, mild colitis, cecum ascending transverse, endo and histopath, but severe colitis descending sigmoid, ulcerations, granulomas, and a 15-centimeter stricture about 50 centimeters from the anus. So pretty much correlates with the enterography. And the TI didn't look too bad. So the clinical course. Remicade was started, methotrexate was added as adjunct with 6-mercaptopurine removed. So I'm going to now break it down, but in summary, between March of 2011 through October of 2014, and I'm going to show you guys some graphs in just a moment, this young lady required gradually increasing the Remicade doses, decreasing the intervals, and even doing this, she did not have adequate levels. And I can also tell you during this time period, she was a little bit better than having an albumin of 2, but nothing really above 2.5 to 3. I am going to highlight surgery was discussed with the family July of 2011. I don't know how those discussions went, but this goes back to Dan's sort of outline of how important it is that we really not, show that surgery is actually part of the treatment armamentarium. A lot of families think it's a last resort or it's a failure, and I always say that surgery used judiciously is part of therapy. And I guess the primary attending at the time discussed veto, but it wasn't approved by insurance, so stayed on infliximab. So radiographic studies, because of the stricture, this again, Dan, you can weigh in on here, but this just shows that this child continues.
It still needs to come out.
Yeah, so basically has strictures. So clinical course. So remember, I've said that we've known that this young lady's had strictures, so between 2011 to 2014, in between, was still on infliximab, not doing really well, had a repeat colonoscopy in 2013. They could get through the strictured areas with an XP scope. Later that year, repeat MRE and colonoscopy, persistent stricture, mild pancolitis. And then a little bit over half a year later, they could not even pass the XP scope, and she also then came in hospitalized in febrile soon thereafter. So she had surgery 3 years after this happened. So I didn't know if you had any comments about we've already talked about the timing of surgery. I think we all agree that this would optimally have been back a few years earlier.
Yeah. The only comment I would make from a technical standpoint is we tend to staple our anastomoses. There is some evidence, although like much of the surgical evidence is not great, to suggest that that's reduces the increases the disease-free interval prior to recurrence, and that the reasons for that are not clear. Whether it's that the staples are very they don't generate much of an inflammatory response, like suture, whether you get a bigger anastomosis and that provides for better flow. It's not clear, but there is some data to suggest a stapled anastomosis, so I would definitely have done a stapled anastomosis.
Any other thoughts from a surgical standpoint in terms of approaches? I know the rest of us are gastroenterologists, but at your respective institutions, is that typically what you've seen, stapling versus hand sewn?
Stapling, yeah.
Yeah, so.
And Dan, did you do a diverting, you didn't do a diversion in this to let the anastomosis kind of?
Would you?
Divert proximal to the anastomosis?
Not in this case, but if someone had a perf and has dirty planes, are you using in the face of primary albumin of 2? I'm just, throwing all these factors out.
Yeah.
Do you sometimes divert proximally?
Absolutely. Yeah. If it's too dangerous or too risky, or you because what you do is compromise a bunch of the other bowel, because you damage all the bystander bowel by trying to chip it out. So I would definitely do that, wait, and go back later.
Right, and certainly some of the complications from what I could tell and what my fellows could see included a post-operative course. There was an intra-abdominal abscess, required IV Zosyn and JP drain, but eventually went home. So good news, 2015. So did better clinically. Remicade actually was spaced to 10 mg per kilo every 8 weeks and had therapeutic levels. And then had a repeat post-operative Upper lower endoscopy, EGD looked fine. Colonoscopy showed a little bit of mild stricturing and ulceration at the anastomotic site and still mild to moderate pancolitis. So the patient is now doing better, but even with therapeutic doses of Remicade, has active disease. And so because of this patient was switched initially to vedolizumab, was eventually at every 4 weeks, still not doing better clinically. At that point, started getting a little worse and was switched to Stelara in February. So I just wanted to point out this graph here. So for all the questions you all had about growth parameters, the arrow shows when she had surgery. So the bottom line is that she basically wasn't gaining or growing, was not anywhere remotely on the curve, but by having surgery, at least started moving towards back towards the curve. So the question is it the infliximab being therapeutic, or is it the surgery? And I think one would argue it was probably the surgical intervention first, and who knows if how much of a role the infliximab played. And this is just a graph, again, that my wonderful fellow actually made, just showing sort of the trends of the sedimentation rate and C-reactive protein, and you can see where things improved, especially after surgery. And then there's the peak in both of the inflammatory markers post-operatively, and that's where ustekinumab was started. So recent status. At this point, you can see the percentiles, growth not great, had a repeat MRE in the spring after she had finished induction with Stelara and had one maintenance dose, had active inflammation at the TI and ileocolonic anastomosis, as well as the distal colon. And labs, I mean, the albumin, granted, is better than it had been, but it seems like it never really normalized. I think it normalized to the mid-3s after surgery, but it stayed sort of in the 3 range. Inflammatory markers are still up, is still mildly anemic. And so now I'm going to end with the most recent colonoscopy and upper endoscopy. EGD, again, was fine. This was just done recently, so I don't have an update, but this young woman has a stricture in the upper anal canal, erythema and scattered ulcers, rectum to descending colon, stenosis in the descending colon, and a stricture at the anastomotic site that was traversed only with an XP scope, and deep ulcerations in the distal ileum. So I just want to show this. So if you recall again, the TI had never been significantly involved, but it seems like it's actually worse. You have true stricturing at the anastomotic site, another stricture even downstream. Other studies, by the way, had immune workups, infectious workups. Genetic studies are still pending. And again, this is where Anne had nicely talked about folks with more severe disease, even if she's not truly one of those VEO IBD children. You know, the thought of our IBD group discussing her is that with severe sort of disease, you know, she falls into that sort of monogenic category. As of right now, I still don't know what those results are. So now the questions for this group. So what's the risk of malignancies here in this scenario? And then the second piece is, are there medical therapies we can still offer? And if not, where do we go? And these are just some of the questions, surgical and other thoughts. So first, in terms of malignancy, what are our thoughts here? I mean, do we have increased risk for malignancy in the colon?
With active disease and
absolutely.
Pre-meds that she's been on?
Yes.
Absolutely.
Right.
I think one of the interesting parts of this case...
We can't hear you.
Oh, sorry about that. One of the interesting parts of this case is that, you know, if you looked at her weight and her growth, she actually responded phenomenally well, at least, I'm going to read into it, phenomenally well to EEN. And you saw her weight respond. It'd be interesting to look at what her inflammatory markers did as well.
Okay.
I mean, she was severely malnourished, and she got right up onto the growth curve. Mm-hmm. And what did the CRP do?
I could. So you can see the...
Yeah, so the CRP actually dropped pretty low. I think sometimes we forget that EEN can actually be used as long-term. Obviously, this is an extremely complicated young lady, and that, you know, there are new biologic therapies that are coming about, as well as small molecules. But I think we have evidence that EEN works, and we have definitely put G-tubes into a number of our Crohn's patients who have actually done well long-term with either total EEN or PEN type of treatment course. So I think that might be an option to think about. Again, it's all dependent on the individual, but it could be a treatment option, as well as the new biologics coming down the road.
And we've certainly talked about it. These are small studies, but there are more studies that actually talk about, when we talk about combo therapy, it doesn't have to be a biologic and an immunomodulator. There are some limited studies that suggest, for instance, that using EN in combination with an anti-TNF may actually help in terms of efficacy. So certainly that's one way to approach it. And then I know that there have been studies that have also looked at a pre- and post-operative enteral therapy to improve outcomes too. And I had checked to see if pre- and post-operatively she had been on EN, and she hadn't. So certainly those are some things, sort of take-home messages, ways you can use EN to actually improve your surgical outcomes.
Sandy, have you looked at, done a wireless capsule to look? So I was impressed because her absorption wasn't really improving, yet it didn't, originally the anastomosis was not bad, but she's still flat. So I was wondering if you had any visualization of the proximal small bowel in someone who continues to not grow.
Yep. So it's interesting, Dan asked me, so I had looked back because it wasn't included on these original slides. She had one at the very much the get-go, but I did not see any, and I suspect it was just concerns of growing possible stricturing that the folks who were caring for her through this time did not repeat the capsule. But yeah.
So I was just thinking that in between after the surgery, but I think you're looking at, okay, so I think options on the table. I mean, thalidomide has been used in very refractory patients. That is a possibility. Second of all, for me, I would tell this family that she needs a end ileostomy, a low Hartman, come back another day when she's fully grown, bones are better. Like, you need to tell them they need to just stop.
Right.
Putting their child, really, all of us need to just take a step back. And granted, the small bowel may still have disease, which is why I asked about the capsule before. I kind of said, take the small bowel out of play.
And Dan actually asked me the same question beforehand too, you're right. So I did not
that-
find a recent capsule.
Feel better?
Great minds think alike.
So that's kind of where I'm thinking at the moment. Let her do her thing. Nutrition as well. So that's still also, even if there's small bowel, enteral nutrition, but get the anastomosis out, get the microbiome off the table for the moment. And that's the way I would manage her.
So basically combo therapy. Would you continue for Stelara?
The question is, again, we keep asking drugs to work in a case like this. When you go back to the beginning, and even though I got hysterical over Pentasa, I don't know whether TNF would have changed the natural history. I'll be totally transparent, because it was already that fibrotic, you saw that fibrosis actually almost at the beginning on the first scope. So I'm not sure, but at least it maybe could have helped. So I think on the table would be, do you revisit TNFs? Adalimumab has not been tried, if I understand, for the moment. We have infliximab, and she was switched because she thought you had good levels, and but maybe not. And revisit, but once you clear the small bowel, I'd like you can ask me after you clear the small bowel, because I'm not sure what.
I'll give you guys updates. Since I don't know. Dan, your thoughts about surgery, and then David and Ann.
I would, as you know, I think the patient needs to be diverted and resect, leave whatever looks like it might at some point by salvageable, which I would, if it's fibrotic scar, that's never going to get better, and take that out of the equation.
No, I agree with the diversion. I think that she has active disease, not responsive, and as Marla already said, she has not done well for a prolonged period. She just needs a quiescent period in her life to recoup. In terms of the autologous stem cell transplant, I would avoid that. There's an adult program at UW which has done or has a study protocol, and that's been placed on hold just given mortality associated with it in IBD. So.
Any other thoughts? All right.